It gives me great pleasure in welcoming Dr. Pawel Zalewski, who's a medical oncologist at the Durham Regional Cancer Center in Oshawa, where he's the lead investigator for several kidney cancer clinical trials. Dr. Zalewski is here to talk about clinical trials and the future in kidney cancer.
Thank you very much, Dr. Baluja, and thank you very much, Kidney Cancer Canada, for an honor to be here. And I just have to start by acknowledging Kidney Cancer Canada. Without you, all the current drugs and the future drugs will never be available here, if not your collaborative effort advocating for these drugs through our government. So big applause for all of your effort. So unfortunately, in spite of the fact that we have very exciting new drugs in use for kidney cancer for the last few years, eventually most of the treatments fail because the cancer cells develop resistance. And there are several mechanisms by which, at least as far as we know, they are doing so, including the hypoxia-inducible factor, also the fibroblast growth factor 1, interleukin 8, and also recently angiopoietin tie system has become known. So the angiopoietin axis is actually one of the signaling models for transmission of the signal from the blood vessel content towards the epithelial cells. The angiopoietins interact with the Tie2 receptor to mediate the vascular remodeling. And at present, we know about the two angiopoietins, angiopoietin 1, which promotes vessel stabilization, and angiopoietin 2, which mediates angiogenesis and actually increases the vascularity in tumors. And actually, in preclinical models, blocking both is better than blocking one or the other. So by inhibiting the angiopoietin axis, we already have a couple of drugs in clinical trials. The first one is called AMG 386. It's actually a peptide sequestrating angiopoietin 1 and angiopoietin 2 and preventing the interaction of the Tie2 receptor. A second agent is called CVX060, is a recombinant humanized monoclonal antibody fused to the angiopoietin 2. So the first study with AMG was actually presented at GeoASCO in 2010. It was a randomized phase 2 trial with 3 arms. There was a control arm with sorafenib at the standard doses and 2 arms with AMG in addition to it at 2 different dose levels. And the trial was basically looking at the progression-free survival. Unfortunately, that study was completely negative. The curves overlap. There is no statistical difference in any way. However, there is a second phase 2 study in a similar fashion looking at sunitinib plus minus AMG. This has already been completed, and I hear that this is going to be reported at ASCO in Chicago this June with apparently some exciting results. So I'm definitely looking forward to hearing about this. The second antibody is slightly behind in development is the CVX060. It's a selective potent inhibitor of ANG2 and has demonstrated activity in clinical models. Now, the study design for this one starts with phase 1 part, when the dose has been established at 15 milligrams weekly, and then it's given in conjunction with axitinib, so one of those new second-line VEGF inhibitors. And the design for the phase 2 trial, again a randomized one, is looking at addition of the drug to axitinib or the axitinib control itself, and again looking at the progression-free survival. We are also looking at another pathway, which is the fibroblast growth factor receptor as a target in renal cell carcinoma. And there is a drug in clinical use called dovetinib, or the other name is the TKI 258, when in phase 1 studies has shown activity with some responses to disease stabilization. The established median tolerated dose was 500 milligrams given on 5 days out of every 7. And toxicity of that include mostly the GI side effects like nausea, vomiting, diarrhea. The drug also causes some hypertension as it affects the VEGF receptor 2. So basically, this study is actually available in Canada as well. It's well accrued, and I think the end for the accrual is going to be in September. So this is the international prospective randomized trial where patients previously exposed to at least one of the VEGF inhibitors and one of the mTOR inhibitors are randomized to either the new drug, dovitinib, versus sorafenib. It's a 1-to-1 randomization. And from what I hear, the study is accruing very well, and the first interim analysis were suggestive of some benefits, so the study will continue to accrue until the very end. The next drug in development is called BNC105. It's a dual activity molecule because it blocks the tubulin polymerization, but also has activity for the tumor endothelium. So it's both cidal to the cells, but also inhibits the vasculature. And we know from the way that mTOR's inhibitors work that there could be some potential for additive benefits here. If we start treating patients with BNC105 with the stress that the drug is causing, there is upregulation on the mTOR in the surrounding tissues. As you can see here, in the surrounding tumor areas, there is upregulation of the mTOR, which led to the design of this study where actually patients who were diagnosed with metastatic disease and progressed on one or two prior VEGF inhibitors are randomized to either the combination of the two drugs or everolimus itself, followed by a switchover strategy to the investigational drug. This study is still in the design phases, but hopefully it's going to be starting rather soon. Now I'm going to switch gears and talk about immunotherapy. Immunotherapy has been in development for cancer treatment for a long, long time. But unfortunately, we haven't had much progress until very recently. For those of you who focus on the other types of cancer like prostate, you probably heard about this exciting drug called Provenge, or Ciploisil T. And this drug basically works as an individualized vaccine. It's the first immunotherapy that has been shown to be effective for prostate cancer, demonstrating improvement in overall survival. The second exciting drug is called ipilimumab, and this is the antibody against the CTLA-4, and this drug has been shown to be very active in malignant melanoma, producing the first ever improvement in overall survival for metastatic disease. So looking at those examples, like people are really focusing in on other types of cancer, including the kidney. So how can we enhance the immune responsiveness towards kidney cancer? Well, we can eliminate some of those expressed peptides like CTLA-4 or PDA1. We can change the tumor responsiveness by blocking peptides on the other side like PDL1. We can produce vaccines, and then we have to select our patients appropriately so we can derive the most benefit. So this is basically what we're trying to do. On one side, on the right side, you see the T cell, and on the left side, you see the dendritic cell. And basically, we're looking at this interaction here between the PD1 and the PDL1 on the surface of the dendritic cell. And if we can block this pathway, this is called program death PD1 pathway, we can derive some benefit. So several tumor types, including renal cell, have shown overexpression of this, and this is associated with more aggressive disease behavior, shorter survival, and impaired anti-tumor immunity. So we really have a drug in development for this. It's called it's a Bristol Myers product, BMS 936558. And the study, phase 1, was presented by Dr. David McDermott. And the design was rather straightforward. So upon enrollment, patients were treated with intravenous infusions of this once every 2 weeks. The cycle was basically 8 weeks long, and then the patients were restaged at those points. And if they have not progressed, then the treatment will continue on. I just wanted to remind you that this is a phase 1 study, so obviously they're looking at a relatively small number of patients and at different doses of the drug. But having said that, they had obviously people with kidney cancer in the study. So actually, it turned out that the drug is well tolerated at every dose tested. There were 3 doses at 1, 3, and 10 milligrams per kilogram. And there was actually no apparent relationship between the drug dose and the adverse event frequency, which confirms that this is not a cytotoxic treatment, but this is actually immunomodulating regimen. The most common adverse events, serious grade 3 and 4, were not frequent, mostly the lab abnormalities, endocrine disorders, and fatigue at very low levels, and only 1 treatment-related death, which was due to sepsis. And again, if you look at the serious adverse events, it's only around 11%, and again, mostly it's the lab abnormalities here. And you can see that the drug effective, this is a 47-year-old patient who already has been treated with interleukin-2 and sunitinib. And now if you look on the panel A, on the left-hand side, I guess, it was scanned in September 2009, and then after 4 months, you see significant improvement. If you look at basically the tumor measurements for those patients on the study, you see that majority either stabilized or showed decline, which is very encouraging. But again, remember, it was only phase 1 study. There was also a question, is there an association from the tumor side, the PD-L1 expression, with the response? And the answer is yes, still looking at limited number of patients. So the response may be correlated for those overexpressing tumors. 3 out of 4 partial responses were seen, whereas in the negative tumors, none. So to summarize, at this very early point, this drug has displayed manageable side effects at all those levels, and anti-tumor activity observed in a relatively small number of patients so far studied. Those responses perhaps can be durable, and there was another 16 patients added to this cohort, and the whole group is going to be reanalyzed and presented at ASCO this June. Responses were also seen in lung cancer. So the current status of the drug is that there is a dose-finding study in patients exposed to prior treatment, and this study actually is available in Canada. Believe it or not, a center in Moncton is actively accruing patients, and I hear that Calgary is about to open this as well. So please check on the NCI website. You can find easy links for that. So basically, this is not the only drug targeting PD-1. So if you look, we have around 5 agents in development at different phases, going from phase 1 to 2, and hopefully at least one of them is going to be of some significant use in the future. So I'm going to talk briefly about vaccines. So I did start mentioning about the prevention. This is somewhat similar idea. So basically, those vaccines are made of dendritic cells enhanced with specific peptides to tumor RNA, for instance, in this example. And this is given in conjunction with sunitinib, so it's a randomized phase 3 trial. This one, I think, is still in development phases. I couldn't find this being open yet. However, the second one is already open. It's the IMA 901 phase 3 trial, and this is available in US. Actually, Dr. Brian Rini is the chair for this project, but the company that makes the vaccine is European, so most of the centers are actually in Europe. So to summarize, we have already established quite exciting pathway here. We're developing agents targeting the CTLA-4 and PD-1, but also there is agents targeting tumor growth factor beta, and there is a new cytokine called IL-21, and now there is development of vaccines. So suddenly, I think the immunotherapy is becoming more and more exciting. As we heard from Dr. Gingrich, the mTOR pathway is a very important one for kidney cancer, and we know that currently available drugs like the temsirolimus and everolimus are useful. But actually, they are targeting only one of the TOR pathways, the TORC1, and this is associated with the heat-induced factor 1 alpha. And there is a separate pathway. So this is the TORC1, but there is the TORC2, which is not quite inhibited by currently available mTOR inhibitors. So we are concerned actually because the TORC2 apparently is even more important, and if we are not blocking it, perhaps that's why we are seeing relatively low rates of responses, and then the disease stabilization is only for several months. So, as I said, the suppression of the HIF-1 alpha has been thought to mediate efficacy of TORC1 inhibitors and the TORC2 associated with HIF alpha 2. So, unfortunately, we have already drugs in development that may be targeting both, like the OSI 027, INK 128, and so forth. So far, they have been mostly in clinical development so far. Another potential strategy is actually dual inhibition of the P13 kinase and the mTOR. There were found similarities between the domains of the mTOR and the subunit of the P13 kinase. And there's blocking two pathways or two proteins at the same time could have additional benefits. So in this graph, you see that there is further inhibition of mouse xenografts treated with this new agent called NPV-BEZ235 versus rapamycin. And rapamycin is the precursor of the currently known mTOR inhibitors like everolimus. If you look at the immunohistochemical stains, in this window over here, we see that the use of the NPV, BC, whatever, has really suppressed the expressive of the ATK. And again, we have a whole group of these drugs in development, and the names are here. I don't think that they are in clinical trials just yet, but they will be most likely very soon. And this is just one of the examples. This is the study of the GDC 0980 versus everolimus in patients with metastatic renal cell carcinoma who have progressed following vascular growth factor inhibition. So this is a randomized study and comparing everolimus to the new drug. So in conclusion, this new PI3 kinase AKT is a viable target in renal cell carcinoma, and several drugs in clinical development, and hopefully we'll be hearing about this more over the next few years. So to close basically my presentation, yes, there is much more work to be done with what we have. Like we probably hear about sequencing of VEGF mTOR, and there is a lot of talk about re-exposing patients to VEGF following mTOR inhibition. But that's easier said than done. You know how difficult the funding and the access to drugs is, and I'm not so sure how often is that going to be possible with the current funding structure, at least in Canada. So fortunately, we have many new drugs in development, and some of these drugs could be well tolerated as we can see it, and hopefully they can be given in combination with Sutent, for instance, or in sequence, and hopefully over the next few years we're going to have many more areas of expertise, and hopefully with your strong voice of advocacy, we're going to have most of these drugs covered. So that closes my presentation. Thank you very much.
Thank you very much, Dr. Zalewski, for outlining all the clinical trials available in Canada. Thanks once again.